Hello, everyone. My name is Dr. Jill Farmer, and this is our second installment of our weekly addresses for Parkinson's Awareness Month. Some of you may know me. I am the director of the Movement Disorder Program at Global Neuroscience Institute, but I do wear another hat, and that is the director of the Movement Disorder Program at the Robert Wood Johnson Hamilton Hospital. And through that role, we're trying to build up outpatient resources in their neuroscience center, especially in movement disorders, amongst other subspecialties within neuroscience. And when I was meeting with key individuals at Robert Wood Johnson Hamilton in their rehab department, because so many people know that in order to treat a Parkinson's patient completely, it's not just medications, but it takes a whole team, and key members of that team are rehab professionals, speech therapy, occupational therapy, physical therapy, just to name a few. And as I was talking to them, they let us know that they offer services in different types of therapy, including pelvic floor therapy, which can help with incontinence and constipation, which then had a light bulb go off in my head, because what we were going to discuss at our symposium on the 17th last week, which didn't happen because of COVID, was urological health and sexual health in Parkinson's disease. Sexual health might be a little bit intimate to just jump into in this new platform. So focusing more on urological health, I also found out that the Parkinson's Alliance recently published one of their patient experience surveys, which focused on neurologic issues in Parkinson's disease. So there were many things from many angles that found out that this really is a perfect opportunity to discuss this in more detail. And as luck would have it, the director of rehab services at Robert Wood Hamilton introduced me to my lovely guests today, Rachna and Michelle, and they are going to talk to us about pelvic rehab, in particular incontinence therapies and constipation therapies, because I know as a movement disorder specialist, many of my patients, when we're going through the non-motor symptoms of Parkinson's disease, we ask about continence and we ask about constipation, and we talk about diet, and we talk about timed strategies and different ways to take medications or medications to help. But I know many patients don't want to take another medication, and as a doctor, I don't necessarily want to prescribe another medication. So when I found out that there were some practical strategies along the same idea of when I tell patients they need to exercise and move more to retrain their bodies and retrain the rhythm of their bodies for gait and balance and things like that, if those can also be applied to some of the non-motor symptoms, I was very excited to learn more. And I thought my patients would be excited to learn more. So without further ado, I would like to allow them to introduce themselves and their expertise, and then we'll start our discussion. So Rachna, would you like to go first?
Absolutely. Thank you, Dr. Farmer, for inviting us to speak on this platform. We are so happy to be here to talk about pelvic health. So a brief introduction about myself. My name is Rachna Mehta. I am a doctor of physical therapy. I graduated from Columbia University. So over the years, I have done advanced study and certifications in manual therapy, in orthopedics. I'm board certified as well. And then most recently, I also got a pelvic health rehab practitioner certification. So I've been practicing for almost 14 years. I've been treating men and women with pelvic health issues. So currently I am at RWJ Rehab in Hamilton, and I'm part of their rehab program. I'm also part of their pelvic health program, and we've been expanding this program to address this population. So one of the things Dr. Farmer recently shared with us was a research report that came out from the Parkinson's Alliance. They talked about many things, as Dr. Farmer mentioned, but one of the biggest things that came out of that report was that almost 85% of individuals with Parkinson's disease have urinary dysfunction. So that is a huge number. So pelvic health rehab is definitely something that we can help these patients with. And that is what we're going to do in this introduction. And we're going to discuss strategies that these patients can do at home or in the clinic under the guidance of a physical therapist so they can overcome these urinary symptoms. So the symptoms that we are seeing most commonly and that they had mentioned in the report were urinary urgency and frequency. These were the most highly reported and most bothersome symptoms. Nocturia, which is waking up multiple times a night. Incomplete emptying, weak urinary stream, hesitation, and straining to urinate. So all these symptoms can fall under the broad umbrella of Parkinson's disease. However, they could also be age-related, and they could also be, a cause of other medical conditions. So that's really where we come in. So when a patient walks in to see us, we are asking them questions. And so first and foremost, we are asking them about the symptoms. What do they have? Why are they here? And then we'll ask them, a comprehensive medical history. We'll ask them, how long these symptoms have been, what other medical conditions they have, and what medications they're on. So really after we have all this information, then we do a comprehensive physical exam. So we're looking at their muscles and their joints and their spine. It starts with the abdominal muscles. We'll look at the tone of the abdominal muscles. We'll look at their posture. We will look at how they're breathing, their respiration. Are they doing more diaphragmatic or belly breathing, or are they more, breathing up here from the chest? Then we come down to the pelvis. We look at the hip joints. We look at the external and the internal pelvic floor muscles. We assess them for tone and for strength. And after that, then we make our recommendations on the findings. So if someone comes in with incontinence, and we find that they have more weakness in the pelvic floor muscles, then we would be doing something like more strengthening. So for strengthening, we can use many modalities. Biofeedback is a huge modality that we can use. It is surface EMG. We use sensors that can be either external or internal sensors that we place on the patient, and they can do Kegel exercises, and that's what we're teaching them. So this is very interesting because one of the biggest issues is to teach someone how to do Kegels properly. The first step is really identifying where the muscle is. So the sensor gives them a tactile feedback and tells them where the muscle is. And then the other part of it is the contraction, the quality of the contraction and their control over either contracting or relaxing the pelvic floor. So when they are on biofeedback and they do a Kegel contraction, we can actually see it up on the screen. So that's visual feedback for the patient that, okay, here's my Kegel, and then we can progress them with the protocols built into the biofeedback program.
Can I ask a quick question?
Absolutely.
So one of the questions I get, I have referred for incontinence therapy in the past, but I must say I have not referred for it often. But a question that I do get, and you just mentioned about external and internal muscles, is,
yes.
Well, how intimate is this type of therapy? How are they teaching me? How are they feeling the muscles? And I honestly don't know the answer to that. So that might be a question that some of the patients who are watching this have, and that might be one of their concerns for proceeding or considering going for this type of therapy.
So that is an excellent question, because this is definitely an intimate therapy in terms of the internal exam. It is a gynecological exam. We do go in either vaginally in women and rectally in men to check the internal pelvic floor muscles. However, if there is a patient, and I have older patients, 85 plus, who have, not been sexually active for years, and, there is loss of estrogen, they do not consent basically to the internal exam, then we can use something called rehab ultrasound imaging. That's a brand new modality that we can actually do an ultrasound of the abdominal muscles and look at the bladder and the pelvic floor muscles from the abdominal wall. So that is a great tool for these patients. In fact, I recently had a patient who had anal cancer. So the skin around the perianal area was extremely raw, and I did do the exam initially just to see how the tone was, but there would be no place to put the sensor. Mm-hmm. So that was an ideal candidate for the imaging, the ultrasound imaging, and it taught him how to breathe properly because he was not a diaphragmatic breather, for one. He was a chest breather. And every time I would ask him to do a Kegel, he was actually bearing down. It was the opposite of what we wanted him to do.
Mhm.
This is somebody who had urinary and fecal incontinence. So the imaging really helped him to see where the pelvic floor was, where the bladder was, and how to do the Kegel properly. So in a proper Kegel, the bladder should actually lift on, and we can see that on the screen.
Interesting.
Helpful, definitely. So other than that, we also look at their diet. And there's a big education component in incontinence training. We are asking them questions about what are they eating during the day? What are they drinking? And how many times are they going to the bathroom or urinating during the day? How many times at night? So there's something called as bladder diaries that we can do with them that tracks that, and we educate them to track that at home. So that is something, patients even now at home, anybody listening to this can start doing. They can just take a piece of paper and start writing down their voiding intervals. So normally in a 24-hour period, you should be voiding about 7 to 8 times a day, which is roughly 3 to 4 hours. So if this is somebody who is going very frequently, say every 40 minutes they're running to the bathroom, then that means that the bladder was not completely full. So that's more like an unstable bladder that's sending false signals to the brain saying, hey, I'm full, I need to go. Mm-hmm. So the other piece of that musculoskeletal exam that I was saying, the abdominal exam, is also to check the tone of the abdominal muscles. So if you have somebody who has high tone there or pain there in the abdominal area, bladder is sitting right behind or behind the pubic bone. So the pubic bone is the bone like right from the abdominals all the way down. When you hit a bone, that's the pubic bone. And the bladder sits behind it.
Oh, I love visuals. Great.
Right. So if there is high tone or tension in that area, the bladder can't fully expand and relax. So if the muscle on top is tight or is high tone, then you see that bladder, there's constant tension or pressure on that bladder, and that's that urgency and frequency. So there are techniques for releasing those tissues that we can do in the clinic, fascial releases and myofascial releases around that. But there are also techniques we can teach the patient to do at home. First of all, it starts with the diaphragmatic breathing and relaxation. And then the other piece of it was the intermittent urination, the start, the stop, the hesitation. That is also part of internal pelvic floor muscles. So the pelvic floor has 3 layers. It has an external layer we can see. The second layer is the sphincter muscle, which is a round circular muscle, and that controls the stream of the urine. So for the start and stop patients, we have to try to relax that layer and work on that. And then the deepest layer is the layer that controls, so say for more stress incontinence, laughing, coughing, sneezing, when people are, those are things that increase the intra-abdominal pressure. And, when you cough or sneeze, it increases that pressure and you actually bear down and you leak. So for those things, it would be more strengthening. So when we actually teach someone Kegel exercises, it's a combination of all the layers that would come into that for, doing a correct, proper Kegel contraction. So other than that, it's also really managing their fluid intake. So going back to the diet. So caffeine is a big irritant. There's teas that are irritating, spicy foods, acidic fruits. These are all irritating to the bladder. So if I ask a patient, how many cups of, caffeine, and that's on our intake questionnaire, to what they're taking. If somebody tells me they're taking, 5-6 cups of coffee a day, and they like to take this nice, warm tea at 9 p.m. at night and go to bed at 10, they're waking up 3 times a night. So those are things we will try to change based on that, and that could help with the symptoms, because it takes about, 2 to 3 hours for our bladder to process all the fluids and then empty before they go to bed. So for somebody like that, I might say, try to take or do the majority of your hydration during the day. And in the evening, just take small sips of water, say if you need to take a medication or something, but really not, huge quantities of water or fluids in the evening. So that's something else they can watch.
I would jump in there just because orthostasis or low blood pressure is such a problem for my Parkinson's patients that I'm constantly trying to push non-caffeinated fluids, water as much as we can. And I often will tell them, being cognizant of the nocturia and getting up overnight to go to the bathroom, to stop drinking around dinner time. And most of my patients' dinner time are before 7 p.m.
That works.
What time, I was going to say, is that a good time that you
So it
usually?
depends on what time they go to bed. So if this is somebody who's going to bed, and I have, patients who go to bed at 11 or midnight,
Mm-hmm.
for those patients, 7 would work. But if there's somebody who's going to bed earlier in the evening, then they need to stop their, fluid intake much earlier. It depends.
Okay.
But it's interesting with the bladder diaries that we'll see they're waking up at the same exact times. It's 1 a.m., 3 a.m. It's
Mm-hmm.
So the bladder is, trained to wake them up at that time.
Mm-hmm.
So part of what we do is also bladder retraining. So we would teach them strategies. For example, the Kegel exercises that we teach them 2 types of Kegels. One is a long Kegel, say working for 10 seconds and resting for 10. And then there are short burst Kegels, working for 2 seconds, resting for 4. So the fast burst Kegels are the ones that help with the urgency.
Okay.
When someone wakes up at night, and I would train them to try these techniques, try the fast burst Kegels, and try, maybe distraction techniques, so that they can go back to bed. So if they are able to override that impulse to get up and go to the bathroom, that would give, information or feedback to the bladder that, hey, I woke this person up at this time, but they didn't really follow through and go to the bathroom. So maybe the next night I don't need to wake them up. So this is something huge because, we see patients with this type of training, even in 2-3 weeks, somebody is able to reduce their nocturia from 3 times a night to once a night.
That's amazing. That is huge.
If they sleep better, they function better during the day.
Absolutely.
So
And then I don't have to give them medicines to help them sleep or figure out if they're not sleeping because they need to go to the bathroom, or if it's there because they're wearing off of their Parkinson's meds, or if it's just sleep fragmentation due to Parkinson's. So sleeping is a huge part of managing a Parkinson's patient symptom.
Absolutely. So if the urinary dysfunction is one less thing to wake them up, I think if they could sleep soundly, that would help them immensely.
Absolutely.
And so other than that, the other thing we also do is, talk to them about their general, stress levels and, how they're feeling. So urinary dysfunction can be extremely, socially isolating for them because they feel like they can't discuss this with their family or friends. They feel, feeling of embarrassment. Even if they go out, they're always searching for bathrooms or, looking for bathrooms, or they may pick a table at a restaurant that's closer to the bathrooms. So things like that, and then the leakage, they're afraid that somebody, might smell it on them. So those are all things, as they get better control over it. Like I had a patient who had been incontinent for almost 15 years after prostate surgery. And within 2 or 3 visits of pelvic floor therapy, he went down from 6 D-pen pads to 3 D-pen pads. So that's huge for him.
Absolutely.
Of life, because like women can still carry the pads in their purses. For men, it's very hard. Like, where do they have the pad to carry it? But I think overall, pelvic health rehab is definitely a conservative option that they can try. All the techniques that we mentioned, and now with the COVID thing, we are also seeing a lot of patients via telehealth. So this is definitely another option. Or in the clinic also, we are seeing patients. So we're available. The other thing I wanted to mention is that we're also doing phone consults for patients. So if they wish to contact us, they can call us on the phone. The main number for RWJ Rehab is 609-584-6640. And if they wish to speak to a pelvic health therapist about any questions that they have, they can call.
That's fantastic. Thank you very much. And we'll pivot now to constipation, which is the other often non-motor symptom that my patients suffer with. And like I said, other than discussing some diet and over-the-counter therapies for that, I know how uncomfortable and how miserable it can make them from just a discomfort point of view, but also how it can make their medications ineffective because they're not getting absorbed the right way. So I had no idea, honestly, and I will admit this, that I knew pelvic rehab for incontinence, but I didn't realize that it was something that can also be used for constipation. So teach us, Michelle. I'm excited to learn more.
Okay, yeah, thank you again for having me here as well. I'm Michelle Della Rosa. I'm a pelvic therapist. I'm a therapist for 20 years, pelvic health for 17 years. And, everyone, I'm passionate about it. Everyone we work with is just so passionate about treating pelvic health. And I've started 2 pelvic health clinics in hospitals before starting 2 of my own as an owner. And now I work with Rachna for the Robert Wood Barnabas Health System in 2 practices called Connect Physical Therapy that are dedicated to pelvic health. So to follow up with what Rachna said, I took all the organs out of this, but I left the bladder and hold on, I'm going to show you. I left the bladder and I left the rectum. So I'm going to show you this top view here, and I kind of have to hold the organs in place here, but so this is the front of the pelvis, right? The white is the bone, right? So just so everybody that's viewing this can see. And this is the spine, up here. And if I take this top view, they're like, the bladder is that roundish ball that looks like a piece of fruit, okay? And this, where my finger is here, is the rectum. And I just want to show everybody how close they are together, because if you've got constipation, if you are backed up, likely you will have urinary issues, okay? So that's really, really important to remember that oftentimes we have to screen for both of these issues. Bladder and bowel, they go together. So if someone is having a urinary symptom, I'm always going to go to bowel. I'm always going to go to bowel and say, hey, what's going on? We talk about pooping every day, So, I don't want to repeat all the things, but that's our evaluation. I know what Rachna talked about. The thing that's important for people to remember is that this muscular group, called your pelvic floor. So this is another pelvis, and these muscles here this is your pelvic floor. I'm going to take them out so you can just see the muscles. This is the deep lay of your muscles. It literally is a 3D bowl, okay? So this bowl of your pelvic floor has the ability to contract, right, and relax. So contraction means it comes together and lifts up, okay? And then relaxation is the letting go portion. And nobody really talks about this letting go portion, And we do measure people's ability to contract. And yeah, if they don't have an ability to contract, we're going to work on that. But for people with constipation, especially our patients with neurological disease and Parkinson's, their ability to let go because of muscles that have too much tone is very, very prevalent all the way down to their pelvic floor, okay? So one of the things that we evaluate, and like Rachna said, we don't need to do an internal examination. It doesn't matter how old you are. I don't have to do an examination on someone that comes in that's 40 or 25 or 60. If they say, I just don't want one, I can still evaluate you, okay? So their ability to come out of this position is going to determine how well they allow for exit. Okay, so I'm kind of starting at the bottom of the chain here, okay? So related to constipation, there's many, many, many factors that relate to why someone can be constipated. But as a physical therapist, we're looking at what are the muscle and bone issues that could be related to why this person isn't going, So part of our evaluation, whether it's external or internal, is going to involve us looking at what are these muscles doing? Are they stuck in this contracted position? Is there a coordination issue? When I want to let go, am I tightening? So that's a different issue, a coordination issue. So that's what the evaluation is about, saying, does this person have the right control over these muscles? Mm-hmm. So one of the easiest things, and one of the first tips that I'll give people, is how to do what we call a pelvic drop, okay? So a pelvic drop is actually the anti-Kegel, okay? So everyone talks about Kegels, and it's like, it's all over magazines, and like, everyone's so Kegeled, It's like, everyone's up here already, right? So the idea when you do a Kegel is I am shortening the muscle. So this whole bowl of my pelvic floor. I am shortening the muscle and I am lifting. That's what a Kegel is, okay? If I'm talking about the opposite, which is what needs to happen for a bowel movement, I need to take those muscles, whether they're tight or not, I need to be able to let go and lengthen them. So my challenge to people is when you're on the toilet, you're having a bowel movement, you think you're done. I'm done. I'm about to get up. Instead of getting up right away, we're going to say, okay, can we sit there for 1 minute and say, okay, I'm going to do my breathing. I'm just going to slow my breathing down. And can I feel the feeling of, I'm going to see if I can feel like the initiation of like, I want to have another bowel movement, or the feeling of, I want to see if I can make my tailbone and my the front part of my muscles where my pubic area is, can I feel like they're coming further away from each other? Can I feel like my tailbone's coming away from me? Can I feel like my sit bones are coming apart? Can I feel like my openings are getting bigger? Okay. So this idea of letting go or allowing ourselves to let go is really, really important for this pelvic drop or pelvic lengthening that oftentimes people don't think about. They're not mindful about. I mean, who thinks about this stuff, you know, but we do, you know? So we're saying, give yourself an opportunity after you urinate, after you have a bowel movement, to say, do I know where my pelvic floor is? Do I have access to these muscles? If you can feel contraction, which most people can feel something, go ahead and contract. Can I feel what it feels like to let go? Can I feel like what it feels like to let go of that contracted position? Let me do a little tightening. What does it feel like to let go? Let me let myself do that. Let me not rush the process. Sometimes people have more urination and more stool because they allowed themselves to do it. It's a safe place to do it on the toilet after urination or a bowel movement, because that's where you're going to empty anyway, right? Mm-hmm. So I would say the first tip I would give people if they are constipated is to start breathing during elimination, that's urination or a bowel movement, and then after the bowel movement, sit there for a minute and allow themselves to let go. And if it's hard for them to feel what letting go is, do a little contraction, do a little tightening, a small one, breathe and feel what it feels like to let go of that. Okay, just for a minute. And with time, people are like, oh, more stuff came out, you know? So may or may not happen, but it's an easy thing to do, okay? The other thing that we look at is abdominal tone. So we're looking at the whole body. We're looking at people's postures. We're looking at their breathing techniques. Yes, we're looking at their pelvis, but we're also going to take a step up and look at their belly and their abdomen. And that's not something that's typical of a physical therapy evaluation, standard one that you learn in school, you know? So because we have the ability to look at that, we can look closely at their breathing, we can look closely at the diaphragm. There's a lot of discoordination sometimes in some of our Parkinson's patients. So we're gonna start looking at that, and we're gonna feel like what's going on in the tone of their abdominals. Is there a holding pattern there? You know, so one of the things that I wanted to share with you also is the bowel massage that we do. So thanks, Rachna, for reminding me that I have a video on this. So we did a video on this, which I hope I can share on my screen here. So I'm gonna see if I can do a voiceover. Okay, if I can pivot to it. Okay, so let me go over. Can everybody see this?
Yes.
Okay, great. Okay, so I'm giving instructions on somebody, and I'm going to show them now how to do this on yourself. Okay, super, super easy. So this person happens to be lying down, but you can do it lying down or sitting. This is what's called, we call it a bowel massage. So if someone is constipated and maybe they have a little bit of backup in their abdomen, okay, they feel full, they feel distension, they feel bloating, you can take, I'm going to come back a little bit. You can take your hand and glide down that way on the left side of your abdomen, starting from your rib cage down to your pelvis. And we do about 10 strokes there. That's following the pattern of the descending colon. Then you can take your hand, come across to your other rib, and you can gently pull. You see it's not deep, okay? You're gently pulling across 10 times from the right side of your rib cage to the left side of your rib cage, and that's the transverse colon, following the pattern there. And let's see if he does it here. Yep, the third part is the ascending colon, and he's going to come up on himself, reach into the right side of his pelvis and gently glide upward. And we do that 10 times as well. Super easy. And if you felt uncomfortable to do it on yourself, someone in your house can do it for you. You know, you could use a tool to do it. So the purpose of this, I'm going to get out of this. The purpose of this is to, you're not pushing stool through. That's not what you're doing, but you're sort of saying, hey guys, wake up, you know, waking up those nerves, having them participate in what's supposed to happen, especially if you feel full. It is such an easy thing. I mean, we put that up like a year and a half ago and we have like 60,000 views on Bowel Massage and everyone's like, this is helping me, you know? So it's important for people to know that even if they haven't gotten to therapy yet, they can start doing something for themselves that involves nothing but their hand, you know, on their belly. And again, it's to improve just the general motion of how things are going in their abdomen, okay? And the last thing I was gonna talk about was just breathing, which Rachna mentioned. Breathing is important because people don't realize that their diaphragm, so where your diaphragm is here, and your pelvic floor on the bottom, it really, your diaphragm and your pelvic floor are gonna work exactly the same. And they're really two peas in a pod. So if you've got quick, fast-paced breathing, likely your pelvic floor is tight, okay? If you've got shallow, if you're breathing with your shoulders, we can tell so many things just about looking at someone's respiration. I don't have to look at someone's pelvis. I can tell you what's going on, you know? And so to start looking at your breathing and putting your hands directly on your rib cage, okay? And start feeling like when I take a breath in, can I open in my ribs? Okay, the ribs are a circle, right? So you want to feel like it's opening like a circle. Okay, it's very, very different than breathing up into my shoulders or breathing even out through our bellies. A lot of people say, well, belly breathing is the best, you know? So, which is totally fine. There's no right or wrong I'm saying here, but in terms of what we're talking about in improving our pelvic floor function, if you're moving a lot in your belly and you're doing nice belly breathing, but your ribs are not moving, well, then that's not that useful. Right. So it's really important that we can put our hands on our ribs. We can feel movement in our, because that's where our lungs are, right? Our lungs are in our rib cage, not really in our belly, you know? So when we open, I want to feel, I'm breathing in. I feel opening as I exhale. I come back together. I breathe in, I'm opening. And as I exhale, I'm coming back together. And the exhale by no means is a force to exhale or a struggle. It's a very passive, soft, no agenda kind of exhale. It really is you know, just leading you into a soft place, okay? Because otherwise we start changing with the tone in our abdomen and our pelvic floor again, okay? So the three things I'm gonna leave you with are really breathing, okay? Which goes along with that pelvic floor kind of drop post-evacuation. This is after urination, after a bowel movement. It's a safe place to kind of let go. And if you can't feel it, do a little pelvic floor contraction and then let go. And the third thing is that bowel massage. And it's coming down on the left side. It's coming across under your ribs, and it's coming up on the right side of my abdomen. I usually tell people to do that one time a day, usually at nighttime before they go to bed. Of course, it can be done other times, but it's just a nice time you're lying down already and everything is calm and relaxed, you know. There are a ton of things we can do for constipation, a ton of things we can do for bladder health, but you know, we just want to leave you with things that are easy and that you can connect to and that are, you know, you can do on your own, that don't take a lot of time and effort. So I hope it was helpful.
Absolutely. I think it was phenomenally helpful, and the video of the massage was great. I'm a DO by training, so
Wow.
I am a fan of hands-on because it is quite helpful for you to kind of get systems moving by giving them a little nudge in the way that you want them to do it. You guys both talked about breathing so much, and I am not a great breather. One of the reasons why I find yoga so frustrating is I'm always exhaling when I should be inhaling and other ways, and it's just not, it doesn't come naturally to me other than the regular passive breathing that you don't think about. Have you done a video, or are there videos that you would recommend to help kind of train and guide people to the different types of breathing that you discussed?
Yes, if you check our YouTube channel out, it's Connect Physical Therapy, you know, just Google YouTube channel. We actually do have guided imagery for breathing. And since you mentioned yoga, we also have a bunch of yoga videos on there, you know. And we also have started doing a regular, like a Zoom yoga for people that have had pelvic issues. So you can always call us about that. Our website is connectpt.org. But I was going to put it up there, but I feel like it's pretty easy to remember. You know, so we want to give people a way to say, hey, like, you know, the gyms are closed, you know, studios are closed, but exercise with us. Because we know what you need, you know? So it's something that it's gentle. But yeah, if you check our YouTube channel out for Connect Physical Therapy, you'll find some great things related to breathing and pelvic health. So
that's great. And included with the video, I will get contact information and we'll put it up. If not as part of the video, then as a slide after when we send this out to the patients so that they can check out your YouTube channels, your websites, the appointment lines and things like that. So one of the things that I try to do is disseminate practical information, and this was extremely practical information that I hope patients will be receptive to and take a little bit of the stigma out of a maybe not so familiar type of rehab. Like I said, everyone always thinks of physical therapy, you know, the big program, and speech therapy, the loud program for Parkinson's, but everybody that manages Parkinson's patients and the Parkinson's patients and their care partners who live with them know that it is more than just the, you know, the balance and the tremor and the soft voice. There's so many things that make up the motor and non-motor symptoms of Parkinson's that affect quality of life. And also for patients, if they are interested in learning more about the survey that you spoke about, this is the first page of it. It's from the Parkinson's Alliance. And it is, they do these patient driven surveys they have thousands upon thousands of surveys that go out. And they've done them on other non-motor symptoms. They've done them on depression and anxiety. This is the latest one on urinary symptoms, and it's available on their website. We'll put that up as well, so you can take a look at it. And if you wanted to get involved and be included in the next round of surveys that goes out, it doesn't cost anything to do, and it's a wealth of information because it brings awareness to things that are important to Parkinson's patients. So that's what we're trying to do, bring awareness and bring, again, practical solutions to try and help manage symptoms and improve quality of life. So I want to thank you both for taking the time and for continuing to see patients during this crazy time. And I look forward to working with you more in the future.
Thank you.
Thank you so much.
Bye-bye.
Bye.